My name is Olivia and I am a nursing student at the University of Michigan. I will be discussing my patient with you today. The patient is a 55-year-old Caucasian male. He has been married for 23 years and has 3 children. He worked as a cook for 10 years and then went on to earn his degree in finance and accounting. He returned to college to earn his master's in business administration following his undergraduate program. He has worked as an accountant at the same company for 27 years. The patient's chief complaint is chronic asthma and allergies. The patient reported that his allergies began when he was just 3 years old. He was principally allergic to leaves and grass. The patient frequently visited the allergist throughout childhood and received allergy shots once a week for 16 years. Over time, he was able to receive allergy shots only once a month as his allergies decreased in interference with daily activities. Throughout his treatment, the patient was prescribed Theodor, which he took every 12 hours for 10 years. The allergies eventually subsided until the patient began experiencing extreme fatigue and worsening asthmatic episodes in his early 20s. The patient's primary care physician and asthma doctor could not find the root cause of the symptom onset. The patient was prescribed very high doses of prednisone bursts, which seemed to lessen the symptoms. The patient followed this course of treatment for 2 years. Around age 26, the patient's asthma once again worsened, causing extreme fatigue. His asthmatic symptoms began to interfere with his activities of daily living once again. At this time, the patient was referred to a pulmonologist who completed a bronchoscopy and pulmonary tissue biopsy. The patient was eventually diagnosed with allergic bronchopulmonary aspergillosis, a disease causing inflammation of the lungs and increased secretion of sputum, which caused frequent infection and scarring of the lung tissue. Aspergillosis is a common mold occurring in many places that most people have built-in immunity for. Patient symptoms included fatigue, chills, lack of stamina, and backaches. The patient was put on a long-term steroid dose to reduce the symptoms. The patient was also diagnosed with bronchiostasis of the right upper lobe, which is a thickening of the bronchioles due to increased inflammation and infection. Since his treatment, the patient has been periodically placed on steroids to manage recurring symptoms. Although the patient expressed frustration due to his disease, he sought out and underwent treatment and carried on with his activities of daily living, even though his condition seemed to interfere. Following his diagnosis, the patient visited the pulmonologist to analyze his environment to determine how the disease could have occurred. The patient and doctor concluded that the patient's work as a cook in a greasy, smoky environment was not ideal. Furthermore, the patient was a victim of secondhand smoke and lived in a house with pets of which he was allergic to. In terms of preventative measures used to treat the disease, the patient took albuterol through ventilation machines in order to ensure bronchial dilation. In terms of health history not related to the present illness, the patient did not report any history of serious or chronic childhood illness. However, the patient did undergo surgery at age 3 for a double hernia. He was also hospitalized for pneumonia in 2005. The patient received all necessary immunizations throughout his lifetime and is not allergic to any drugs. He is, however, as mentioned before, allergic to grass, leaves, mold, pet hair, and other environmental allergens. The patient currently takes 10 milligrams of Singulair once daily to manage his asthma. He also uses an 80 microgram inhaler, 2 puffs twice daily, as well as 2 puffs of a Ventolin inhaler twice daily. The patient perceives himself to be relatively healthy, with the exception of his asthma history. He reports that the asthma is under control and is not as severe as mentioned in his history. The patient reports alcohol use only at social gatherings. He exercises 5 to 6 days a week for a 1 to 2 hour period. The patient receives adequate rest, reporting 7 to 8 hours per night. And the patient reports no history of smoking, but expresses that he was exposed to secondhand smoke his entire life. The patient uses caffeine rather heavily, consuming 4 cups of coffee per day. He also reports that he has a fulfilling family life and is happily married to his wife of 23 years. His 3 children bring him great pride and happiness as well. The patient noted work as his only perceived stressor and practices a Catholic faith. In terms of family history of disease, the patient's father died of lung cancer. The patient's mother is still living with a health history of Meniere's disease, hypertension, high cholesterol, gastric ulcers, and other anxiety-related illnesses. The patient's maternal grandmother died of ovarian cancer. His maternal grandfather died of leukemia. His paternal grandparents both suffered from COPD and died of natural causes related to old age. In terms of overall perception of general health, the patient reported that his asthma no longer limits his activities of daily living, but he continues to use caution. The patient reported stable weight and energy and does not have any excessive fatigue. The patient visits his primary care physician annually and his pulmonologist twice a year. The patient has an integumentary history of childhood eczema, which correlated in severity with his asthma. He had very dry skin, erythema, and cracking of the skin as well. The patient's current integumentary concerns revolve around his vitiligo on his upper neck, as well as cherry angiomas spread throughout the patient's back. The patient reports that sunscreen use is very important to him and that he uses it whenever he is exposed to the sun. He did not report any noticeable changes in his skin, nails, or hair. The patient recently had a growth on his neck biopsied and it came back negative for skin cancer. The patient did not report any headaches, migraines, or pain in his ears, eyes, nose, or throat. The patient wears glasses and contact lenses but does not have any cataracts or symptoms of glaucoma. The patient reports that his hearing is acute. He annually attends the eye doctor and receives a dental exam twice a year. He denies having frequent colds, reports no trouble swallowing, has no history of radiation therapy, and no neck pain or tenderness. The patient does not report any concerning cardiovascular symptoms. He does not have any chest pain, arm or jaw numbness, and no history of heart disease, murmur, or palpitation. The patient's blood pressure was measured at 115 over 75 millimeters of mercury. The patient's resting heart rate is 57 beats per minute and his respiratory rate is 13 breaths per minute. The patient reports some pain in his hip flexors bilaterally. He claims the pain could be related to his frequent exercise riding the stationary bike. The patient has no edema or coolness, and varicose veins are absent throughout the body. The patient reports no symptoms of indigestion or heartburn. He has normal bowel habits and receives colonoscopies every 5 years. The patient does have a history of colon polyps. However, the polyp biopsy came back negative when tested. The patient reported more frequent nighttime urination or nocturia. He does not have any history of abnormal prostate. The patient does not have any neurological history. He did not report any numbness, insomnia, loss of balance or coordination, or concern regarding his memory. The patient has had no history of head injuries or concussion. The patient did, however, report a lifelong history of anxiety. He claims that he has learned to manage his anxieties throughout his lifetime. The patient reports no musculoskeletal pain or weakness. However, he expressed concern for tightness in his bilateral hip flexors and lower back, as well as some mild shoulder pain. The patient attributes his pain to repetitive motions during exercise. The patient did not report any muscle weakness, decrease in range of motion, or symptoms of arthritis. After physical assessment of the patient's respiratory system, the patient exhibited mostly normal findings considering his history of asthma and chronic bronchial issues. The patient exhibited no visible abnormal findings. His chest was normal in color, AP transverse diameter, and symmetry. The patient did not have any visible injuries on his chest. The patient's breathing pattern was smooth and did not appear labored. He had a respiratory rate of 13 breaths per minute. The patient's trachea was midline and straight to the body. There was no palpated evidence of abnormal expansion or symmetry, no tactile fremitus present, and the ribs and thorax were aligned and symmetric without any deformity or tenderness. All of the anterior and posterior lung fields were auscultated and revealed normal sounds. The patient did not present any abnormal crackles, wheezing, or bronchi. Upon assessment of the patient's integumentary system, the patient's hair and nails appeared normal. Capillary refill was less than 2 seconds. The patient did present with several areas of skin discoloration and vitiligo on his posterior neck. He also had many cherry angioma spots dispersed throughout his back. Other than the listed abnormal findings, the patient had healthy, soft, and well-circulated skin. Aside from assessment of the respiratory system and the integumentary system, it may be advantageous to conduct a physical musculoskeletal assessment to explore the patient's reported stiffness in his hip flexors and lower back, as well as the pain reported in his shoulder. Supplementary to the musculoskeletal assessment, it may be helpful to conduct a cardiovascular assessment on the patient as well, due to his reported lifelong anxiety. Furthermore, the scarring of the patient's lungs and constant burden of asthma on the patient's lungs, there may be some indication of alteration of his heart function as well. According to the Mayo Clinic, patients with symptoms consistent with asthma may be further indicative of heart failure.